that I have been so excited about a technology's ability to democratize access to health for everybody on the planet in a way that is not just high quality, but could also be incredibly affordable for people everywhere. It's already, we're seeing that it's transforming the way that medicine and healthcare are practiced and investigated. Just recently, for example, Google was really proud of the Nobel Award that was, prize that was awarded to two of our Googlers in Google DeepMind. You're going to hear from a Google DeepMind team member today. That was for AlphaFold 2, which before it came on the scene, we knew that we were able to recognize the structure of about 200,000 proteins on the planet. And after AlphaFold 2 came out, we were able to recognize about 200 million, the structure of 200 million proteins on the planet. Just the scale of that in a very short period of time, but also that a model like that is open source and available and being used by some 2 million researchers around the world gets me really excited about how technology can be made available at scale to advance science to customize treatment and services. It's also true that AI is already being used every day in healthcare practice. In many cases, that's to improve diagnosis, to assist radiologists in reading a mammogram or a pathologist in reading a pathology slide. But it's also true that we're starting to see the use of these new general purpose models as agents to carry out tasks, sometimes administrative, in the healthcare environment, such as helping a nurse at the end of a shift summarize a record and start to do a handoff. We're in early days in the journey for how these newer models can be helpful in the healthcare environment, but it's exciting to see them starting to become part of a healthcare team in many places on the planet. It's also, I think, worth recognizing that these models seem very poised to solve what are uniform global challenges in areas like rising cost, some of the socio-demographic challenges that countries are facing around the world, and as well as the health challenges that are being faced, but also workforce challenges, whether that's shortages, burnout, or capabilities of the workforce. It does seem that at the end of the day, we're going to have a world in which AI has been able to bring more personal and personalized services, care, treatments for people all over the planet. And I think it's a really exciting future that we will all need to build together, because what is true is that this is going to require collaboration, and it will also require all of us to be thinking about the responsibility inherent in developing and deploying these models and assessing their effectiveness in the field. As we do it, we have to think about the ethics, we have to do this work transparently, and we have to think about equity. Equity by design as well, because what we don't want is for these models to help solve problems just for some people in some places, but really to help it for everyone, everywhere. Turning AI into reality is going to require the thinking of people like this on this panel, and today we're going to cover many of these topics in the session. I'm going to introduce them in a moment, but first I'm just going to make sure I tell you what we're going to cover at a high level. We'll be discussing some of the exemplary use cases already in practice in the field. We'll be talking about the ethical dimensions of developing and deploying AI, talk about the importance of the AI-human interface and the importance of having humans in the loop and putting people at the center of these systems, and then, of course, how we can all work towards doing this collaboratively. I'm really delighted to be joined by this very distinguished panel of people with very diverse backgrounds, and I think a wealth of knowledge and perspectives from all over the planet, and I'm personally very eager to hear their insights. I'm going to take a moment to introduce them at a high level, and then we'll get started. Just first to my left is Commissioner Amani Abu Zaid from the African Commission for Infrastructure, Energy, and Digitalization. Her experience is quite wide-ranging, actually, and involves continent-wide integration of initiatives such as Africa's AI strategy, Africa's digital transformation strategy, and African single electricity market, just to name a few. She's a leading voice for Africa on the global stage and has been advocating for universal energy access, digital transformation, and sustainable development for her career. Next, we're going to be joined by Dr. Max Alber, who's the co-founder and CTO of AI Agnostics, which is an AI company spun out of Charité. I've been in Berlin for about 24 hours, and I think Charité spins everything out, as best I can tell today, including I haven't spun out the WHS. AI-agnostic's mission is to turn complex biomedical data into transformative insights for biopharma companies. And Max leads the technology organization as well as overall ML strategy, machine learning strategy at AI-agnostics. He has a PhD in machine learning and a strong background in AI research and is leading the AI-agnostics foundation model development for histopathology. Next, we have Dr. Joëlle Barrel, who is the Senior Director for Research and Engineering at Google DeepMind. She's based in Paris. Her portfolio is also diverse and includes basic research on the frontier models, as well as early stage research into the application of those models, not only into Google's own products, but in partnership with academic organizations and companies around the world. She is generally in charge of all of Google DeepMind's efforts in healthcare. She's the author of numerous patents, and I just wanted to say they range from maternal health to surgical robotics. It's a pretty broad background of experience that you bring here. And finally, we have with us Bern Montag, who is a theoretical physicist and is the CEO of Siemens Healthineers since 2015. He's a leader in medical technology, as is the company, and they are committed to not only bringing healthcare technology to help people in the world, but very particularly focused on seeing that they can improve access to healthcare for underserved communities and to address some of the most threatening global diseases. The company has positions in medical imaging, diagnostics, cancer care, as well as minimally invasive therapies, as well as advancing digitization and AI in healthcare. So as you can see, we've got some folks with some pretty broad backgrounds and from different parts of the planet, so thank you all for joining us today. All right, we can clap for them, that would be nice. All right, let's get started. Oh, and listen, I'm gonna ask questions for somewhere in the neighborhood of the next 50-ish minutes. And then at the top of the hour, we're gonna throw it out to you all for your questions. So get your pencils out, start thinking about what you might wanna ask our panelists, and we'll have an opportunity for that later in the conversation. Commissioner, I'd like to start with you. You know, sometimes we've talked about this, that people, when they put Africa and AI in the same sentence, they think, how do those two things go together? I hope that you might give us some broad reflections on that innovation in the space of the continent, as well as some of the opportunities you see for it being helpful to improve health for people.
Thank you, Karen, and allow me first to thank you for inviting the African Union to be in this event. It's very important to us. And I myself, well, it's true, I'm currently the Africa's official in the areas you mentioned, infrastructure, energy, and digital. But I'm also originally engineer through and through. So you understand that my passion also for technology and what it can bring. Yes, true, people would not usually associate Africa with digital or with the advanced technologies. But let me just say that the region that is fastest in terms of digitalizing is Africa. And the fact that for most sectors or for most things we don't have a legacy allow us to adopt technology maybe faster than others. We don't have to retrofit. We can right away adopt, what is coming and adopt, the latest. The fact also that Africa is the youngest in terms of age group region in the planet means that our young people are, eager and hungry to use, adopt, create, and innovate. So on the contrary, I think if there's one region in the world where we should think about advanced technologies, especially AI and digital, it is and should be Africa. So this is the first point. Second, why AI and why for Africa? It's a journey that we started some years ago for digital transformation in the continent. Our continent is 55 countries with different levels of development, and also even the sectors, depending on the sector, different levels of development across the continent. And at the African Union, our mission is a united Africa. So our aim is to proactively have coordinated, unified policies, strategies, allow us to work together and allow us to exchange information, in this case would be data together, allow us, to create these single markets, digital market, as well as one of the things that we are trying to have for Africa. So this is the journey we have been through, digital transformation, and with that comes also specific, I'm sure like most countries, telemedicine, e-health, you name it, now AI. AI is economically, we talk about $13 trillion in terms of the economy. And our ambition is to have at least 10% of this economy coming to Africa. So one, it is economic growth for us. Again, benefiting from all the assets I just mentioned, especially our young people, as our most precious resource. Second, many of the problems, and here health, the health issues in the continent, not different from other regions, can be solvable through AI, help us, in real time, get accurate information, take decisions fast, speed and scale, reach those who cannot be reached because it's far, analyze, depict, prevent, you name it. So AI can do wonderful things, and especially in a continent like ours where there is lack, of health personnel. There are out of reach areas, and also by the time they reach a health facility, the disease has advanced or the outbreak, has already taken its toll. Again, sometimes blessings come in disguise, and I'm here among, health specialists and doctors. COVID, as damaging and as tragic as it was, reminded everybody, how can this save lives? And the campaign we launched and the work that we did under COVID, we called it like this: saving lives, saving livelihoods, because in our case, it was also economic. It was a big economic problem, and we saw, especially at our continent, we are almost 99% covered when it comes to the use of mobile. How can this save lives? So on the contrary, it is in Africa that we want to use not only AI, but not to use it sporadically, because currently only 7 or 8 countries on the continent have specific AI strategies. We want it to be a common story. Different paths, but a common story, not just one here, one there. Some examples, I can give examples. No, we want this common story for the continent.
I love that, having not a unified strategy, but at least a strategic approach. Your comment about people making assumptions about what works on the continent was reminded of a visit I recently did to Morocco, where the minister was showcasing a clinic in a box, essentially using remote sensing and telehealth and technology, and then all the patients in that new program they have get their health record on a chip. These are things that most countries are still dreaming about, and they're actually acting on rolling it out. It was quite inspiring. Before we move on to Max, could I just get you to tell me the flip side of the optimism you have for the continent, and what are the challenges that you see there?
The challenges are probably furthest from what you would have or think in other parts of the world. Simply, there is no electricity in most places. More than half of our population do not have access to electricity. 75% of health facilities in sub-Saharan Africa do not have access to a reliable source of electricity. I know you would not think of that, but it is the main challenge. Same thing goes for the infrastructure, whether it's high-speed connections, having the right equipment, and of course, like everybody else, of course, you need the people, and the number and quality of people that are needed to drive this change are not there. But the lack of infrastructure, the lack in terms of connectivity and or energy is definitely one of the crippling challenges, not just for AI, for many other things. That is why, I mean, you said the single electricity market, and I can also talk about the single digital market and the connectivity. We are speeding up all these things because they are the backbone and the basis for anything and everything. But we are not just defined by the challenges. We are also defined by the many, many, many wonderful things that we are doing, and many of our countries are doing. You mentioned Morocco. I can mention also Zambia or Zimbabwe. Here it was mentioned Rwanda. To mention my old country, Egypt, the only country practically in the world who scanned 100 million people for free for everything, and it has 100 million data sets for each and every individual, and they did that in what, 1.5 years or 2 years for free with the treatment. So it's, and take with that, the analysis of these data and everything that goes with it. So there are fantastic examples on the continent, but again, we don't want to keep citing 3, 5, 6, 7 countries. We want the 55 countries to row on this journey at their own pace, yes, but all of them has to row through this trajectory and strategic approach or objective.
I love that vision. Thank you.
You're welcome.
Max, can I turn to you and we talk a little bit about implementation of AI in practice, and in the context of your own work in pathology or more broadly, could you just talk a bit about how you've learned about overcoming implementation of the use of AI in everyday clinical practice?
Yeah, happy to. Before addressing some of the challenges, I would actually like to say that we have the basic ingredients for success on the table. So especially with the leaps forward in AI developments in the recent years, we are in principle able to build AI systems, also in healthcare, that are smart and robust enough to really have transformative impact. But unfortunately, we are not there yet because there are some challenges. And I think the first ones are, as you said, also infrastructure, even in the first world. And here we start with the need for comprehensive digitization in both research and clinical environments. Because if you go to a hospital nowadays, there's still too many handwritten notes flying around. And at the best, sometimes they're just scanned and then forwarded as an email. And here, substantial investments in infrastructure, such as, for example, slide scanners or advanced storage solutions in pathology, but also there are other examples in other fields, are essential. Because without this foundational layer, the deployment of AI becomes nearly unfeasible. And this reliable and also standardized data access is the key to actually deploy AI. Then another point is the scalability of AI solutions, and particularly in the context of global healthcare disparities. And while health systems may adopt technologies more swiftly in the first world, it's crucial to establish pathways and solutions for low-resource settings in emerging markets. And this involves also making AI systems less compute-intense and also increasing the compute clusters at local healthcare centers or in the cloud. Because if we would now deploy AI in all healthcare, we wouldn't have not enough compute resources, not even at Google. So I think we really need to scale to roll out AI in practice. Especially if you want to make this regardless of the geographical and economic context of people. Once the technical and infrastructural hurdles are addressed, the next significant challenge is mastering and actually also calibrating the regulations, as well as building trust among clinicians. So for AI to be certified and adopted as a reliable partner in research and diagnostics, systems must be transparent, interpretable, and closely aligned with existing clinical decision-making processes. And earning this trust is essential for ensuring the clinicians view AI not as a replacement, but also as an enhancement of their capabilities. And adding to that, there are some complexities. For example, if you take this from the view from a technological and AI, or let's say science of AI within healthcare standpoint of view, the landscape of disease complicates AI integration. Many conditions are so infrequent that pathologists only encounter them once or twice in a year, or even so infrequent that they encounter them once or twice in a lifetime.
Say that again.
Some conditions are so infrequent that pathologists encounter them once or twice in a year, or only once or twice in a lifetime.
Extraordinary, isn't it?
And While doctors are really good at identifying those unusual cases, AI is not. AI is really bad in identifying outliers. AI is great in identifying those 10 categories, you teach it, but saying, oh, I don't know this is strange, that's not its best expertise at the moment. And while it is okay for, let's say, ChatGPT to give you, in 5% of the cases, a bad answer, or to generally perform bad on specialized questions, it's not okay for healthcare AI. Here we need to be much better. Thus, enhancing AI's ability to navigate this long tail of disease is crucial for a safe and effective rollout in clinical practice. And here, all the researchers need to do some more work. And moreover, the current process of discovering biomarkers reflects human imprecision. So the whole system is made that a human is there who judges in the end what should be done. And even if AI can mimic that current process, we still may not fundamentally change the whole healthcare system. Thus, the entire system, starting from new drug discovery to matching the right patient with the right drug by doing clinical studies, by discovering new biomarkers and complementary diagnostics, must move towards a precision medicine approach and embrace individualized approaches for patient care to really reap the benefits of AI in their full potential. And I think we need to address some of those challenges first before we actually can also talk about best practices.
Have you seen any examples of best practices where the physician or clinician and AI are partnered in a way that there is sufficient trust for the clinician?
To be honest, not in the oncology space, because there's no AI that passed the regulations so that it could be used in clinics.
So it's still early days in terms of the use cases.
Definitely, especially with those high-end specialized cases like oncology, it's still difficult.
Yeah.
But I see it in research, so there it really makes a difference already.
Can you give an example there?
For example, we have a drug discovery project together with Bayer, and where we use multimodal AI. And the way how we do it, it really is a data-driven approach and helps to uncover bigger data sets, more multimodal AI, and discover new insights that were, I think, not possible before.
Maybe we can come back to that a little bit later when we do the other round. I want to talk a little bit about automation bias and what we might be thinking there. I'm going to go to you, Joelle, if I might. Maybe I could get you to start with kind of the trajectory of what's already being used in AI in clinical practice, and then how some of these newer models are starting to change that paradigm.
Yeah, thank you, Karen. So, many of you raised your hands, so you're probably already using AI with some of the, what we've called narrow AI, when we are leveraging the tools as to answer one particular question. So for example, with Google, we've done a lot of work in mammography, where we're leveraging AI to help do better screening. And it's a project that we started in 2020, so it took us a couple of years to really go through the clinical validation before we could then deploy, and we've recently finished a clinical study with the NHS. So that's a particular example, and you can picture similar things with chest X-rays or various types of medical imaging. We even did some work in colonoscopy, for example. And those are already, and maybe you will also allude to it, already deployed, for many of them as tools in clinics. Technically, I think that's a very particular type of AI, because you first get an image, and then you post-process it to have the AI provide you with a solution. There's another bucket of AI tools that I personally really like, because they touch to your point of human-AI interaction. It's where the AI is in the loop, where there's interaction between the physician and the AI. So an example that we've worked on is in maternal health, where ultrasounds can be really hard to take and really hard to interpret, but both are coupled. It's true in MRI as well. If you don't take the right image, you're going to have lower image quality and usually a worse diagnosis. So it's important to give the feedback right away to the technologist or the person doing the exam. And with ultrasound, we've done that for maternal health so that you can really help make sure that the probe is positioned properly, and you get the best image you could get for that particular patient, and then you also help interpret those images and provide a diagnosis. And then we can move into some of the things we are all exploring right now with large language models. We've done early work with Google DeepMind that started with our large language model Palm and did MedPalm. How can we fine-tune it on medical corpus to see how good it is at answering medical questions? And that proved out to be way better than we pictured when we started the project. And you might have seen some of that work with MedPalm, MedPalm 2, MedPalm M multimodal, where really models today are at the level of experts or group of experts when it comes to answering questions. Of course, not a single clinician spends their day answering questions. So that's only a small part of what's needed to really make them useful in practice. And then we've made them multimodal because answering based on text is also only one small part of the story. So we have the medical exams that we're talking about, all of the lab data, sometimes also waveforms of various types, very large pathology slides, as we just discussed, and getting the models to not just understand one modality at a time, but understand them together, understand the medical images with the electronic health records, and try to make sense of all of that data at once is really opening up new ways of explaining what's going on with the patient and potentially come up with a better diagnostics. So I would say while on the narrow AI, we've now seen and a bunch of those applications went through regulatory clearance, et cetera, we're way earlier with large language models. And we're really exploring a wide range of potential applications, from the more mundane of helping with some of the administrative tasks of healthcare to the more critical in how we provide care for patients.
Joel, could you give a little blurb about AlphaFold and just talk about how it's being used, maybe give some examples?
Yeah, absolutely.
It's been in the headlines and you literally work there.
I could give a little blurb or a very long one, depending on what you want. So AlphaFold, I think, as you alluded to earlier, is the technology that was rewarded with the Nobel Prize in Chemistry last week for Demis Hassabis and John Jumper, Demis being the founder of Google DeepMind, and John Jumper, one of my colleagues, researcher. David Baker was also co-awarded the prize. And AlphaFold initially started because we had a good competition. There was a benchmark, there were public data sets, and the question was, could machine learning techniques help with that challenge? Earlier, and maybe I'll do a 5-minute or 2-minute detour if you allow me. Earlier you asked who has leveraged AI. I'd like to ask who has built a benchmark here, who has actually, raise your hand if you've ever built an evaluation for an AI system. A much smaller group. I would actually encourage everyone to write their own benchmarks. Like, what do you want those models to do for you? How are you going to judge them? And it's important you keep that to yourself so that you don't contaminate model training. But that's very important because when you have a benchmark, then we can start becoming better against it. So that's exactly what happened to AlphaFold at the beginning, right? There was a good benchmark for protein folding. And we first showed with the first version, that we actually were doing better than other methods. The true breakthrough came with AlphaFold 2, and that cracked the code, solved the problem, and was able to predict for most proteins known to humanity the 3D structure from the amino acid sequence. And then we did AlphaFold 3, which went beyond just proteins to other biomolecules that interact with those proteins. And AlphaFold 3 is really critical if we want to start, for example, discovering new drugs, because you need to understand the interaction of that protein with the rest of the environment. You need to identify a particular target, et cetera. And so you were asking in terms of concrete examples of where AlphaFold has been helpful. With AlphaFold 2, we worked very closely with experts that unanimously told us to make that capacity available to the world, and so we did, right? It's something that is open sourced and people can leverage it. And we saw an uptake that I think no one expected, where today more than 2 million scientists around the world are leveraging AlphaFold. And they use it for a wide variety of things. It can help with understanding crops and food security. It can help with, I was just saying it, with designing new drugs. It can help with enzymes that digest plastic. So we've really been impressed by, I think, the variety of ways people have leveraged it. And I think that also speaks to why it's important to responsibly make such technology available to the broader, as broad as possible, a group of scientists. It wasn't obvious to us, and I think what's important in how we did that was also that we didn't do it all at once, right? We had a phased approach and working with experts in ethics and law, et cetera, that allowed us to make sure at monitoring that at each stage we could actually do so safely.
When we come back to the round about ethics, maybe you'll talk a little bit about reasons to be careful about open sourcing models. Bernd, I would like to turn to you, whose last name I learned a little while ago. Montag means Monday in German, so my brain wants to call you Dr. Monday. And there, I just did it on the stage. Would love for you to talk about how you and the company think about bringing these technologies out into the real world to address not only improving the quality of care, but the lowering cost of care, and do that in a way that reaches everybody, including underserved communities.
Yeah, so some real life examples, yeah, because basically when we do AI, we apply it to real world challenges. Yeah, so we have we last year won the German Deutsche Zukunftspreis, for an MRI scanner, which is based on AI, and the AI-based image reconstruction algorithms allow to relax the hardware specifications of the product, so that we can basically build a product which is much more affordable, much more easier to use, and the AI is just an integrated part of the product. As one example, we have AI which helps position the patient in an exam, so that automatically, the best image quality is generated and the best protocol, so this radiology language is applied. We have AI for looking at lung images, even in an emergency case, and then you check, have I overlooked the lung cancer? Which you normally don't do in the emergency room, or you might be distracted as a physician. We have AI to do the right treatment plan coming from a CT scanner and to program our linear accelerators. We have AI, as you know, in radiation therapy, people need to come to the treatment often. Typically, there's a change in the organs, people might lose weight, and so on and so on. There's AI to adjust the treatment plan for the actual situation, and so on. I mean, you might call it narrow AI, so for us it's pretty cool, because it's solving real-world problems, So, but we are also working our way up, in terms of, on the one hand, for example, looking at large language models to help radiologists when they read images to get in an easy way additional patient context from patient history. But we are also looking at bigger topics. We are starting a collaboration with Mayo Clinic on here's image data, here's other data on the patient, and we want to train a, let's say, multi-information source model to avoid the need for prostate biopsies. So I think the main message here is we are starting with real world problems. How to make MR easy, more affordable. How to solve staff shortage problems. How to make sure that in the night shift or in the emergency department proper care is delivered. Or how to avoid prostate biopsies, and then AI is the method to do it, but it's not that we say here's the AI thing which we do for the sake of doing AI.
When you build those sorts of systems, do you all have specific strategies that you need to use to keep the doc from just clicking the X in the upper right corner and closing the prompt box with the results, or do you worry that they're going to either not read it or rely on it too much?
I mean, I think this depends very much on the use case. Yeah? I mean, in this MR scanner, you don't even see that it's based on AI. Yeah, I mean, it is AI. Yeah, so and it would be weird if you say, do you really want to use this product? Yeah, or when it comes to patient centering, it is not there. Yeah, but then I think it becomes difficult when a medical diagnosis is done, and there we are still in that largely in the situation like autonomous driving. Yeah, so that still there is the human who needs to tick off, yes, this is the right thing. Yeah, but a lot of routine work has been taken away and done by the AI robot, so to say, but the final quality check needs to be done by the human. Yeah, so I mean, this at some point in time will also go away. Yeah, but in these type of use cases, we need it. Yeah?
Yeah, I love the way that you're describing, like, it's sort of in the background, being supportive in the moment without it having to be very...
It is built in. It is in the machine itself. You don't see it, like we are not seeing AI. I don't wake up in the morning and say, let us use AI. It's in everything that I do, practically, without knowing.
To be fair, we probably use AI every day when it auto-completes your email and your text messages. So, yeah, exactly right. We've gotten so used to it every day. And I think, Joel, you had your hand up?
Yeah, maybe just to emphasize on the example, right? Because it's very similar to what I was saying about ultrasound. When you get an MRI, the technologist traditionally is the one who is setting up the right plane, et cetera, and that takes time. And in a lot of the cases, you don't end up with the best exam you could get. There's a lot of variation depending on who is scanning. And I think removing that variability from the picture, literally, really provides the best data to start with that you can then leverage to provide a diagnosis. And so I think those examples are actually very important because they're not the obvious one. They're not always the ones we think of. We think very often about diagnostic examples. But in practice, they really both can speed up the exams and really provide consistency of care, which we'll see in AI more broadly. Like this idea that with AI, you get the average technologist to be as good as the best technologist, or the average nurse to be as good as the best nurse, because they have either part of the work has been quality controlled and they can improve on how to place, the exam to properly scan the heart or whatnot, or a feedback loop that is reducing errors. And I think that's something we see very broadly with AI.
Maybe, if I may,
yes.
I will be brief. Yeah, sorry. See, but I think there's one topic also which we be mindful of: having people and then AI on top is a luxury problem, which many LMICs don't have. Yeah, so the topic of how does the AI work with the physician and what's the liability and so on and so on. And I want to do the analogy. We often speak about digitalization, as an analogy. Digitalization means something exists, when you take it literally, and now you make it digital. Then there's a different approach, is a digital first. Where you make something possible for the first time which hasn't been there. And this is also an important aspect of AI. And another example from we have a collaboration with the Global Fund on screening tuberculosis in Indonesia. Where it's about how to read chest X-ray images. And there it's not about, and to see whether there's tuberculosis. It's not about how do we help the radiologist or so. The alternative is no scan. And I think we have to distinguish also in our discussion whether we do an AI in terms of improving productivity enhancement, quality improvement, or whether we use AI to make something possible for the first time.
I mean, I personally hope we do both over time, but I love that framing. Thank you. Yes, Commissioner.
Yes, I mean, I was going to tackle another point, but wow, that's what I said when we don't have a legacy, because we can afford to do that process digital from the start. So if it's digital, and where there are humans, then that's another story, or there are processes. Well, we make a difference between digitized and digitalized. So anyway, but I wanted to tackle another point because I was fascinated by the work that is everyone is doing, and especially here on this panel, to draw the attention to the fact that, and you asked me about challenges, for us, the use of AI in health and any other sector, the main challenge is that it is not and was not designed for us. So the algorithms, even the genomes, I mean, that are used for the analysis are based on non-African genomes. The data sets are not even housed in Africa, so which means use in analyzing is not valid. The pathologies we're talking about, the behavior of people, what is happening, not happening, none of this is African. That is why also one of the main reasons where we said, well, we have to develop our own capabilities in that field in order to make it able, well, I'm going to use non-technical term, I mean, think or behave, I mean, use AI in ways that can serve an African context, ethnicity, age groups, behavior, climate, because the climate affects pathologies, issues. So that's also very important because as it stands right now in any field, it does not make a difference, it does not at all distinguish Africans from others, where things are very different, especially in the health field and other fields as well.
Well, thank you for turning us to that, which is, I think, on the what you can get excited about all the things it can do, but there's some realities about the challenges of the models, whether they're data input, technical, the inclusion and design approach in the beginning, and perhaps the list goes on. So maybe y'all will help fill in the list, and we could talk some more about the responsible part of AI and how we should be thinking of developing models in the today world, single-shot AI, and then the tomorrow world, which are these general purpose models. And Max, do you want to start with any thoughts you have about some of the ethical or data or other challenges?
May I just?
Yes, ma'am.
I mean, I hope you'll touch upon this because we also want it to be ethical, by design.
Yes.
Not as a retrofit, which is
Yes.
which is also now happening. That's just
No, happy to do
another
that.
point.
I think I want to pick up your point. And when I thought about this, I think the key problem is we want to have the same standard of care for everyone.
Yeah.
And how do we have that, or how do we know that we have that? We only have it when we can measure it. And how can we measure it? We actually need the data. And the problem is that there's not enough data generated. And when I was thinking about this, I think the practical problem is there needs to be funds that data will be also generated and made public in Africa, Asia, South America, and so on and so forth. For example, in oncology, the biggest data set that everyone is using is TCGA, which was funded by North America. And thereby, everyone is doing research on that one, and all the research and all the models, everything is biased towards that data set. Mm-hmm. And this is one of the problems. I think the key problem to really make AI working for everyone is actually generating the data. Because making the AI is not the problem. Actually, the data access and the data generation is the problem.
Good.
And it feeds on data, so that's why we have to increase the use and generation of data in order to allow this to happen.
Yes, and it's also true related to benchmarks and how we think about what good looks like and think about what bad looks like. Do you want to add on to anything they've been sharing about the responsible AI development?
Yeah, absolutely. So first, I would say it's critical, as you said, to think about it from the get-go, right? And at Google, we established responsibility principles as early as 2017, and the researchers were the ones spelling them out, right? AI has to be beneficial to society and accountable to society. And so I think that's really because it's actually not an easy problem to solve, right? The data we have is heavily biased. So working on the data is one part of the solution, but we also have to think about other dimensions. For example, starting with our teams, right? The people that are working on the algorithms, that are building those algorithms, where do they come from? Who do they represent? How are they going to bring diverse perspectives that are going to make sure that we don't have a very biased perspective on the world? So starting with the teams, looking at the data and making sure that data that's representative of more people is included. That's important for everything we do with large models. Even more so in healthcare, I would say, because if tomorrow I need care and I have something relatively rare, the likelihood that someone like me, just in my neighborhood, has the exact same thing is fairly low. I will be much better cared for if we've included data from many more places. So that's especially acute in healthcare. And then we also are working on the models themselves, the algorithms, to compensate for some of the biases we're seeing. So I think that's probably one, I would say, of the good things of generative AI is that we've realized how biased the web is, and the fact that, you know, if you're searching for an image of a woman, it will have between 20 and 30-year-old, and it's not the case for an image of a man. You can try right now if you want. And so I think we really realized that, which we hadn't probably noticed as acutely prior. So we are kind of all really working on also the underlying models to see how we can teach them that the data is biased and that they should compensate for it. So I think that's the kind of three broad buckets to try to get at the bottom of those challenges. I would add as a fourth one the way we deploy those models and the environment in which they're used, where making sure people are aware of the limitations of the model and keep a really critical eye when they interpret the results, because no matter how hard we work on the technology, at the end of the day, I think you really need to make sure people are still watching for exceptions and cases in which the technology is not relevant.
Yeah, it's a good point, and it relates to this automation bias problem that some folks have talked about in the space. And I mean, in my career in medicine, I remember when EKG machines started to spit out the report, and when I started medicine, nobody ever looked at those. We were taught not to believe it. We were taught that you had to read it yourself, and it was just some ancillary thing. And I think over the course of years, not only has the technology gotten better, but I think people have gotten more dependent on, oh, well, that's what the technology is, the reading that it automates. And sometimes that's helpful because it will streamline the work of clinicians, but I think what some people are worried about is that there will be an over-reliance without using critical thinking and sort of just being discerning about what the models will bring forward, not just for clinicians, but for people in every day. Bernd, I want to go to you to talk about challenges, and somewhere in your answer, I hope I can get you to talk a bit about the regulatory environment, if you're willing, and sort of where that may or may not be sort of helping us think about the promise and where we would, global governments might need to start thinking about safety, et cetera.
Yeah, so I mean, maybe a short comment on the question before, but really short. I think it's really, really important when we talk about AI and ethics that we don't discuss on a super high level, because it's really about the use case. Yeah, because the ethics of our MRI scanner, which is based on AI and uses a lower field strength and gets what's the ethical problem? Yeah, we want to solve. Yeah, or what's the ethical problem of better patient positioning? Yeah, so I think we have to be specific, and I like your benchmark topic also. Where do we see, in which class of problems do we see ethical challenges? Yeah, this is when bias comes in, and this is to some extent when AI maybe is over promising. It's like, well, this is, but I think we need to be specific, and we cannot just apply it on the big word AI. Yeah, we need to look at a class of issues, a class of problems with an ethical topic. Now, from the regulatory point of view, there's a big part of medicine and development of new technologies in medicine which is regulated already, yeah, and which also applies to a large extent to AI-based algorithms, yeah, and the question is, and then you don't, it would be an over-regulation when on top of what we need in FDA language as a 510K or as a pre-market approval or whatever, that you say, oh, and if it involves AI, then you need to also do this and this. Yeah, so typically the existing processes are not so bad. But I think then comes a certain topic of where it comes to the strength of AI, and this is, I think, in the non-narrow AI. How do we regulate situations like what you described? Yeah, where it's a user interaction and AI, or what I also find super interesting is Because currently in most of the AI we are using, it is, so to say, software developed by AI. Yeah, it's an algorithm which is based on AI, but when it's on the system and it's used, it's a fixed algorithm, yeah, which was not developed by a human but by AI. Okay, so but now the question becomes, in the future, if the patient who gets treated or whatever or diagnosed today is influencing the model. Yeah, when you get to some kind of a closed loop mechanism, that the AI is trained in real world, in the real life, in the real world. Yeah, so this, and I think we are still some years away from this in reality. Yeah, I think then we really have an interesting regulatory challenge. Yeah, because then we are basically not approving or giving approval for the product, but for the process of refreshing and improving the product. Yeah? And I mean, I'm sure there are thoughts about this, but I think this is one of the interesting challenges. Yeah?
I would like to answer to this point, but well, the examples that have been given here are more in, you mentioned MRI, you mentioned, the analysis of a picture, but this is not just it, in terms of health and healthcare. Remember, we talked about data sets, huge data sets of your population with the various issues, and you want to talk also about policies based on these data sets, medication distribution based and vaccines based on these data sets. And there are serious issues of privacy, serious issues of security being misused by some pharmaceutical companies, even national security issues, misuse of these data sets in so many ways. So I think the health and AI is much more than just the machine for diagnostics for diagnostics or a particular remedy. Even this, the algorithms is or even the position of the patient, as you mentioned earlier in the example. Maybe, I don't know, maybe we sit differently, I don't know, or we stand differently, or our rooms, the rooms that we use for such machines are different, pushing us to maybe have a different physical position. What I'm trying to say is that, no, it's much more than this, with all the due respect, and I approve of what you said, but it's much more complex than that, and much more beneficial, and also, how would I say, risky, if we're not by design paying attention to these things. And to go back to a point that was said also earlier, we are doing this, yes, of course, when it comes to research, R&D in general, and healthcare in particular. We want to benefit from, all of us, from all these huge data sets, data going back and forth across the world, because we are not alone in this, on this planet. But at the same time, issue of data ownership, issue of data use, these are very, very important issues, and you have to manage the two very carefully. It doesn't go one just, open and then everyone can use whatever or whatever. It doesn't work like that. So regulation is tough. Regulation in Europe is very complex, and I'm not sure that it allows, lots of innovations. Maybe if there are startups in this room, will tell us more about regulation and AI. Regulation in general, when it comes to innovation in technology and digital in particular, I don't know, they always have this, they're always very tense. And innovators, they go very fast, and regulation is trying to catch up all the time. Crippling very often, if they are not flexible enough, if they are not, strategic enough, they can cripple innovation. They can stop it. So even when we developed our strategy, we are working with regulators to make them understand, and to make them understand the need of being agile, of being flexible, because we don't even still, none of us around the world has mastered everything about AI to say, well, this is, the book of regulations that you should go by. So that's another point for regulators to be agile, to be flexible, to know that this is an evolving technology. And yes, of course, they have a role because it's a technology that it could be double-edged, like any technology. It's not specific to AI, for that matter.
I think so much of that is true, and one thing that's been really encouraging to me is that regulators around the world, parliamentarians and others, are getting as educated as they can about AI and the new gen because of your point, I think all of your points, that this is a sort of, we have a way that we can regulate AI now. This is a new generation, and it's going to have new dynamism that I think everyone's going to have to be as knowledgeable and smart as possible. I don't know, Max, anything on regulation before as a startup?
Yeah.
Or you go to the last question?
I think it's actually, I don't think the regulations are a problem. I think they, as Bernd said, I think they're good, and in principle they're fine. Of course, they don't address challenges like if the AI has not a certain input-output structure, so Gen AI will be a real problem, or self-learning systems. But per se, for the most use cases, I think they're good. I think the bigger problem that I see is the whole system, because it takes the benchmark is good, but it takes so long to get an answer by regulators. So they easily pass 2 to 3 years, and this really cripples innovation, because it takes too long until you get through, until you get feedback, and so on and so forth. And I think it's a little bit like in pharma, that all the regulations will help the big players, because they have the means to go through all this regulation. They have the stamina to go through over the time and stay. While for startups it will be difficult to put up the capital and also the time and so on and so forth to get
Where did you get your capital from?
Sorry?
Where did you get the capital from?
We get capital from VC funds.
Yeah, so you still also need to have this within a country or a region way to mobilize funding for startups, which is,
Definitely.
again, another issue for startups.
Yep, and it's a whole ecosystem.
Yeah.
Exactly. To get to practice, there will have to be some benchmarks and then regulation on the other side. All right, audience. Yeah, wow, okay. And right in the front, too, predictably. Well, let's start in the front. We have microphones going around, and we have lots of good questions for our panelists. Thank you.
Okay. Okay, thank you. Am I audible?
Yes.
Okay, yeah.
Please.
Thank you so much for the discussion. My name is Natalie, and I'm representing young people, healthcare professionals from Ukraine. And I do have 2 questions. It's understandable that if you want to work with AI globally, you have to cooperate with the government. So the first question is, what characterizes healthcare systems that are ready to work with the AI? And the second one, what are the benefits for the government? Because let's be realistic, if you're coming to the government saying that we diagnosed 1 patient faster, it's not an option for the government to accept and invest. So what are the real arguments for the government to implement those ideas and technologies? Thank you.
Maybe quickly.
Oh, you want to take 3 and then people can answer them? That's a good suggestion.
We did, yeah, 3
Commissioner's managing my panel. I like it.
Okay, thank you so much for the discussion, everyone. I'm Theo. I'm representing the International Federation of Medical Students Association, a federation currently representing 1.5 million healthcare students. So our question is towards Dr. Albert. You briefly mentioned the trust clinicians put in AI models and how that affects the integration of AI models in medical practice. How can we address these concerns, and what do you envision the role of youth and healthcare students in capacitating the new generation of clinicians?
All right, we'll take one more question and while they digest those, and then we'll answer, and then we'll go back out. There's one maybe right here. She's got a mic.
I just had a question about, I come from Australia, and I just had a question about AI in aged care. I don't think any of the participants touched on that. And the second thing is, I think you very well alluded to that. Who owns all this data that's being harnessed from all around the world? And what we have on the panelists, we have 2 from Google, 1 from Siemens, only 1 from government, and 1 from a startup in some ways. So the funding for AI and AI generation is a big factor that plays a part.
Thank you. All right, who wants to take the first question?
I can take the first one. So I think in terms of, who can start leveraging AI, I would say it's a fairly broad spectrum, as you mentioned as well, right? All 55 countries, not just a handful, each at different stages. But so I would say, broadly speaking, anyone can benefit. Now, depending on where you are on your digitalization journey, and I think to your point, some are on that journey, some don't even need it, you will leverage the tools differently. But I think it really depends, again, on the use cases and what the problems you're trying to solve are, regardless of the technology. And very likely, AI can actually help you solve those particular challenges. Now, in terms of the governments, in many countries in which you have a universal healthcare coverage, for example, the governments are, of course, an integral part of the stakeholders and the people that are very interested in healthcare. In most countries, we have very big challenges with an aging population in some countries, or a very young population in others, with very high costs associated with healthcare, with a workforce that is not always sufficient. And so healthcare, AI really can look at each of those challenges precisely and bring solutions. So I would say, again, the specifics matter, but in most cases, it's really perceived as an important tool in your toolbox to really come up with solutions.
So so this is maybe, I don't know, maybe provocative or maybe stupid what I'm saying, okay? So you decide, yeah? So see, in the end, I wonder if in 5 years, yeah, when we have a World Health Summit and we have a panel called AI in Health, people will hopefully laugh at us. Yeah, because it is, if we had this panel and it would say computers in healthcare, yeah, people would say, come on, first, 2 topics. First, computers are everywhere. They are at the receptionist, they are in the X-ray machine, yeah, they are in our pockets, yeah. So computers were a technology so and so many decades ago, and they made inroads in healthcare in many, many, many places, okay? Whether it's in the Minister of Health, or in the radiologist, or in pathology, or whatever, yeah? So, and then we would say, okay, first of all, they are everywhere, so what type of computers are they talking about in this panel? And secondly, why is it a topic? Because the topic is, this is a means to an end. We want to talk about how do we end cancer, yeah? And AI is one of the tools we use for doing this, yeah? So, and from that point of view, yeah, if you think of it from that point of view, yeah, that, I mean, and it's a medium intelligent analogy, I admit, yeah, to say AI is today what computers were a couple of decades ago, yeah? Then the question is, what is your AI strategy? Suddenly becomes a bit weird, yeah, because who has a computer strategy? Yeah, or what is the computer strategy of a government or whatever, yeah? So it is a tool, it's a super powerful tool which you apply in very, very different use cases. There is a lot of AI in the products, whether you want it or not, yeah, because it's, as I said, it's part of many things we are doing. In our case, I know it's only the diagnosis, yeah. And then there are topics which are on a government level, yeah, like population health management, epidemiology, and then you get into data privacy questions. But there are other problem classes where it just doesn't matter, yeah? And I believe we are in that topic where AI will not be the top-level topic, yeah? It will be part of everything on a cellular level, more or less, yeah? And then I think the discussion will also change over time, yeah?
Provocative. Thank you.
I want to get to the questions that were asked. I mean, I assume that your question was partially answered or was answered previously, but investing in AI is investing in healthcare, investing in better healthcare, in a nutshell, because it's speed, it's more accurate, it's real time, it is efficient, it can save lives, it can save money. I mean, you name it. But I want to go back to the issue that was raised here about data and data ownership, which is really a huge, huge issue and a very, very critical one. AI feeds on data. We need to produce data massively, and that's what we're trying to do in Africa not because we want to produce data, but we want to connectivity and growing, I mean, with connectivity, those skills, so people to benefit, fully benefit from even that cell phone they're having, I mean, with all the potential it brings. Having said that, how do you feel if your medical file was lost? How would you feel if your medical file is someone for some reason stole it or is on the street? How do you feel if your medical file was burned because there was an accident where it's archived? This is happening. This is just a small, it's a huge issue for you. Such a small problem. Imagine the population, the data of whole population, for instance, or a region, or a country, or a village are sold, which is the case and happened. It did happen a few years ago. I'm not going to name the company, but a famous company which we use practically every day when one of the social media, they sold the data of Africans to a private entity to use it to influence elections. So it is dangerous. It is a weapon. So unless you own your data, regulators also work with the private sector, because a country, I mean, public sector, it's not only the public sector who generates or works or manages those data, but you put, you know, when we spoke about regulation, how to use it, how to store it, where, what's happening on the cloud. The cloud is not up there, by the way, it's everywhere. So what's happening exactly on the cloud, who has access, when, how, while at the same time allowing exchange, because researchers need to work together. You need to know about an outbreak happening somewhere before it comes your way, about a new discovery, about a new disease or an old disease coming back, whatever it happens. So data is a huge, huge issue. And when we mention AI, we have to mention data. And we have to mention how it is owned, used, where is it stored. And also, even when you go to the even smallest machine, the algorithm that was fed into this machine to interpret a certain image or a certain behavior or a certain composition in the body is based, in our case, on a non-African body, on a non-African genome. So de facto, in most of the cases, depending, of course, of what is it that we're talking about, the interpretation is not what necessarily applies to us, because maybe our behavior is different, our diet is different, our ethnicity, our genomes are definitely different. So what I'm trying to say is that for AI to work well, for all of us to reap the benefit of it, what goes in has to be healthy. I mean, what is feeding AI has to be healthy, has to be safe and secure, and has to be adapted to you and to your context, so as the output is also safe, secure, and helps you get a better health, better life, longevity, if we talk about ages. I'm talking in oversimplifying the matter, but it is, I don't like when people complicate things, you know, using lots of technical expressions, jargon, but this is how it is. It has to be safe, healthy, adapted to you, to also allow us to have safe, healthy, real to you, not to someone in the North Pole, real to you solution or decision.
Very helpful, thank you. And I think one of the questions was for you, Max.
Yeah.
So do you want to take that one?
Yeah, didn't fully understand, but I think it's how to basically convince physicians to use AI.
Yeah.
And I think there are several factors there. If I think about now pathologists typically nowadays still have glass slides and look at them under the microscope. And the first thing there is actually, it would for them to be a hurdle, because they would need to switch on the computer if they want to use AI. It takes them more time because they can do their case in 10 minutes. So I think the first thing is actually integration and digitization, so that they move away from analog and physical devices towards digital computers and all digital workflows. Then you can plug in AI much more seamlessly. And then I think the next point is that AI needs to bring value, either being faster, more accurate, or solving new problems. by, for example, there was a recent announcement by AstraZeneca. They have, I think they are the first ones in oncology who actually drive now complementary diagnostics, which is basically a test that you need to do to prescribe a medication. And that one is there to basically identify the right patient population for their drug. And you need to use that AI tool actually to prescribe the drug. And they had done tests before that a human could not do this test before. So they really need to use AI and have the precision of automation and so on. And I think there, AI starts to really transform the healthcare, what I meant before, and actually bring additional value.
Great, thank you. All right, more questions.
This.
Got a microphone over there. We have somebody who's enthusiastically wants to follow on.
So
we'll
thank you. Thank you so much for your interesting input. So Amani Abu Said just said one size doesn't fit all, and we want really to arrive at personalized medicine. But in medicine, we are not doing particularly well. For example, women have more side effects on a bunch of medications, and so and Max, you were already mentioning that the importance of taking outliers into account. So I would like to hear.
Women are not outliers.
No, absolutely not. No. But
please.
No. But in addition to the very basic differences that so there are more smaller subpopulations. So I would like to hear data at the moment are not systematically capturing heterogeneity of patients, and how can we integrate that into electronic patient files so that we get better data that so that we can actually deliver AI to personalize healthcare.
I believe you said it. I mean, you have the answer in what you said. I mean, if you'd allow me, AI is a wonderful tool because it can make the difference if we have fed it. I mean, the algorithm was fed to make a difference between a male, female, young and old, living outside, living inside, your lifestyle, so on and so forth, to also prescribe something that would not harm you if it's prescription, or give a solution that is adapted to that person, whatever the situation of that person is. But what you are alluding to is a very real issue, which is, again, very often, not necessarily in medicine, the algorithms do not make a difference between male and female. I know it's not the discussion here today, but because I'm also in charge of infrastructure transport, road accidents are a major issue, and treatment of road accidents are a major issue. Health measures in a car are not designed for a female body. So the damages that happen to a female body in a car are not the same like what happened to a male passenger. These are things that, as a doctor in emergency, it's very difficult. I mean, to take decisions or to diagnose, it's an emergency case, but that is why that's the beauty of technology, that sometimes it can help you take these immediate decisions and solutions for very complex and very urgent, could be very urgent situations where you need this decision. So it all depends how you fed this, if it's machine or if it's an algorithm, how you fed it. But definitely the issue of inclusion of everybody, we're not just a person. I'd love that, but it's, we're also, we have to celebrate our differences. And in this case, it is celebrated in the sense it has to be inclusive of our characteristics, our geographic location, ethnicity, way of life, age, and so on and so forth.
It's a great question, and maybe we're gonna take two more questions, and then we'll come back to the panel to answer. And while we're doing that, while we're passing the mic, can I just tee up for you, Joelle? At some point, maybe you and Max could talk a little bit about partnership across the world and how that starts to help build a more comprehensive picture that's more diverse of the people we're here to serve.
Just before getting into, because I mentioned it, I'm keen because there's another big campaign I'm leading. I'm also leading, a campaign to advocate for changing the safety measures in cars to be adapted to women's bodies.
I'm 100% sure that you are, with all the passion that you have. It's beautiful. All right, over here.
Hi there, Peter Liu. I'm a physician scientist by background and here representing Oxford Cancer Analytics. So I'll give the context. We're using AI to identify novel protein-based biomarkers in the blood and transforming that into a simple blood test to detect cancers early when they're still curable. We're initially focusing on lung cancer, and on the point on involving low and middle income country data is essential for that, and I'll give an example why. For women who are of East Asian and Southeast Asian descent, there's a specific cohort who are significantly more likely to get a particular type of lung cancer without ever smoking a single cigarette in their lives. None of these women are currently part of the current guideline, which is based on past year history and age. So having that type of data involved in an AI algorithm will be essential, because the data that's identified from that is not only helpful for these women who are of East Asian and Southeast Asian descent, but the biomarker that corresponds to their particular type of lung cancer can also be used in any other countries with that particular type of lung cancer, be it if they're women from Southeast Asia or East Asia or any other parts of the world. So, but the challenge is that we don't have that much data coming from low and middle income resources. It's much easier for us to work with partners in the UK, in North America. We do have clinical trials ongoing in India and China, but that's a minority. So what are currently some of the public sector, private sector infrastructures and collaborations are enabling more data, more samples to be available from low and middle income settings? And how can smaller and middle stage companies work with such infrastructure to help patients?
Okay, we'll come back to that in just a minute. And I heard that people are moving from this side of the room to that side because the mic's I like that. Y'all are so proactive. I'm not in charge of the mic, so everyone's looking right at me like I'm gonna save you. Oh, the enthusiastic fellow there.
Yes,
This is good. Congratulations.
So Claudio Tanca, Global Alliance for Surgical Obstetric Trauma and Anesthesia Care. By the way, there is a way to collect data in a low resource setting. It's called the Operative Encounter Registry, and it's already available for people to use. But my question is to Dr.
Can you say that again? I'm sorry. What is
Operative Encounter Registry. It's to collect data from operating room, patients' data. So it's already available. But my question is to you, Dr. Montag. I bet your company is in the business of making device technologies, and the biggest chunk of your revenues, profits are from high-income countries. However, there are like 8 billion people in low and middle-income countries that have needs that at the moment are not fulfilled, or needs that are not even considered by companies. Have you ever thought about using AI to analyze those needs and come up with technologies and products specifically for low resource setting environments? And if you have not yet considered what it would take for your company to consider this type of products and technology? More investments, more data, perhaps with more data we can help. Thank you.
All right, let's take one more question.
Can I go? I already have a mic.
Go for it.
Yeah, thank you. So I just would like to build up on what you just mentioned, because I recently collaborated on a research on AI talent workforce. So we found that, not surprisingly, there is a big underrepresentation of women in AI talent. So globally, it's like around 22% of women in AI, and in Germany, it's just 20%
in
of
STEM
women.
in general, so that would be more or less the...
So my actual question is building up of this, if there is an awareness of this issue of the lack of representation of women in the AI workforce, but also if you see this lack of diversity like a potential way to reinforce these biases you've been mentioning, because more inclusivity will mean that the AI will be able to deliver for the particular needs of women and for underserved communities. Thank you.
Thank you. So I hear three things in this. Maybe one is how can we address bias by doing a better job of the data that informs and builds the models? How do we make sure that the people working on the models themselves are representative and diverse? And then as we apply them in the field, how do we make choices or think about where we apply? So I'm going to ask the three of y'all to take one of those. You have to take the last one. Who wants to take data in, and who wants to take diversity of workforce? You're going to take data in? All right.
I can take the diversity one.
Oh, okay, then Max, data in.
I can take the data. But I think everything was probably said. So first of all, I think we need to make sure that we generate the data. And maybe we need to be smart about it, and like for lower resource settings, that we actually start making devices that measure for a lower cost, and then build AI models for that, and so on and so forth. Or in general, I think create more funding, also globally, to build those data sets. I think that's crucial. So somewhere the money needs to come from. And then to unbias the systems, I think you also said a good point that AI developers need to make an effort. And I think that's also one of the key things in AI, because if you want to have something generalizable, you really need to see how is your data composed. So you need to have good data, well-characterized data, and then also see how it is used in the model training. And ultimately, I think the thing that matters the most is what I mentioned before. I think we need to be able to measure the bias. If you cannot measure it, we'll never know if it's there or not.
Terrific, thank you. Joelle, diversity of the workforce.
Very briefly before, on the person who asked about clinical needs globally, if you haven't looked at the Stanford Biodesign program, it has a global arm, and it has also done a lot of very interesting work to see how generative AI can help shape clinical needs and really understand them deeply, so that then you can start addressing them with solutions. So I encourage you to look at that. In terms of the diversity of the workforce, indeed, we are not very many women in technical roles in AI, and that is indeed a challenge. To my earlier point, in terms of really having a diversity of perspective, I don't think we can do too much to encourage young girls in particular to look at careers in STEM that lead to careers in AI. And venues like this one, I think, are wonderful because they show that with AI you can do good. And often people don't come to mathematical sciences or computer science because they don't see the link between that and doing good in the world. And I think the more we showcase examples where really having the technology gives you a fantastic tool to really have an impact at scale, I think we'll be able to draw more of the talent and really build a more diverse workforce.
And visibility.
Yeah, give them the reward and the recognition. Dr. Monday.
Thank you. So, to your question, I mean, so I don't know the exact data whether our distribution of revenue is resembling or is like the global economy. Yeah, but to give you a little bit of feeling, yeah, 30% of our revenue is in the US, 15% in China. Yeah. This country is maybe 7%. India is a little bit on the same level, and I would say that, roughly speaking, that LMICs are probably about 1/3 of our revenue. Yeah. So, but still, we are not happy about this. Yeah, because I know, yeah, that I mean, taking the US as an example, yeah, only 4% or so of the world population lives in the US. Yeah. And is 30% of the revenue, yeah? So something is wrong, yeah? Or when you look at what percentage of the world population lives in Africa and what is there. So we are not in balance, yeah? So, but to give you one feeling what it means for us, yeah? So we are a little bit strange at Siemens Healthineers. Our fiscal year starts on the 1st of October, yeah? So, and I'm just about to go to our leadership kick-off meeting next tomorrow, yeah? And one of the key topics will be how can we do this better? Yeah, we will have in this one-day topic. Yeah, we will have Isabel Mestre from City Cancer Challenge. I had lunch with her today, and she was very vocal, and she was right about something we didn't do so well. We will have a representative from UNICEF. Yeah, we will have customers from Indonesia addressing our team in discussions to really make sure, yeah, that we understand what it means to work in a low resource setting. And the big change we need to make is we grew up, and I include myself, I never worked in another company, yeah, so that we grew up in a world where we believed, okay, yeah, I mean, the diagnostic machines as an example. Everything is taken care of. Here is New York University. They have a building, they have a radiologist, they have a reimbursement, they have a tech, everything is there, and now what they need is a CT scanner. Huh? So, but we are in the process of overcoming this and thinking, no, we need to help building up the environment. Yeah, you know, if we wait until the infrastructure is there, it's going to be too late. We have to build partnerships. Yeah, this is why we work with NGOs. But we are also looking from financing to whatever, but also to the topic of AI, making it possible for the first time without having to educate people. Yeah? So, and this is the Indonesia example where we do tuberculosis screening based on AI, and not in order to help a radiologist or so, but it wouldn't be possible without. Yeah? So I think we are not at zero. Today I told Isabel, yeah, we are at 15% of what we need to be, but we have a clear intent to take this serious. Yeah?
Thank you. All right, we have 3 minutes, and I want to do a quick lightning round with each of the panelists. We will not call the panel computers in health next year, and but I think we'll probably still be talking about promise to practice of AI next year. And if we were here, what do you hope will be true about AI when you're up here next year? You want to start for us?
All African countries have not only developed their own strategies for AI, but also started implementing them.
I love it.
In all sectors, that's for sure.
In all sectors, you said, yeah.
You go for it all the way.
I love it. Max?
Yes. Yeah, coming out of computer science and AI world, I think healthcare is moving quite a bit slower, so I think topics will be very still similar. But I really hope that we see more examples where AI goes into diagnostics and really solves the hard problems, and that is more robust.
Thank you. Joel?
You all raise your hand when I ask who has built a benchmark.
That's a good one.
Bernd?
So I hope that we don't have that panel anymore in 5 years.
Yes.
It was 1 year, just 1 year.
One.
Huh?
Just next year, 5
Next
years, I
year.
hope we don't have the panel. We'll be talking about agents, but that's a whole other story.
Oh, next.
What do you hope is true in 1 year?
Yeah, so I mean, my little private mission is to say AI is a tool.
Yeah.
And not a target in itself. Yeah? And I think if we make one step in this direction to say, how do we beat cancer with AI? How do we solve health equity with AI? Instead of AI as the first question. That would be a good first step.
I'm on board with that. Thank you all very much, panel. Thank you.
Good.